Thank you so much, Lee. And I want to just take this opportunity to thank you, Lee, for organizing this, and Joy. We really appreciate your work on behalf of Altman, and these great opportunities to get to talk with everybody about what we're passionate about. So I really appreciate that. I would also like to thank Sarah Newkirk. She is a student studying with me from Ohio University. She is doing a phenomenal job at her internship here. Her training at Ohio U is very unique. They take 2 whole semesters to learn about therapy for people with dizziness. And what you all are going to learn today is that that is very uncommon. Medical schools, physical therapy schools, they do not usually teach how to kind of address dizziness in great detail. So she's done extensive training. I've had extensive training at Emory University. I did some extra courses there and just over the years. So she's going to be participating with us today, which I think is great. I'd like to also thank a lot of you for coming. I recognize some of your names. I know some of you have been patients of mine, and so we thank you for hanging in there with us. For those of you who are in the community and are kind of wondering what in the world is therapy for dizziness, we're looking forward to talking with you about it, and thank you for attending as well. And then we also have some special guests today from Ohio University. Dr. Howman, Dr. DeLorme, and Dr. Crow will be joining us, and they are Sarah's instructors, and so it's very special that they are willing to take their time with us today. And finally, some of my awesome colleagues and my boss is with us today. So just thank you all for being here, and it means a lot. And I'll tell you, I am so passionate about helping people with dizziness. I've treated thousands of cases since the year 2000, and what we're going to share with you all today is what we have learned makes a huge difference in people's lives. What we'd like to do is hear from you all. So we're going to talk for about 40 minutes, and then we want to hear what questions you have at the end. But if you've ever been dizzy, and I'm sure some of you have, which is why you're here, you know that it is very hard to explain sometimes. And a lot of times we want black and white. We want to know exactly what's wrong. But the truth is there's a lot of gray in the dizzy world. And so talking today with you all about the big 3, we're going to cover ways to help those where it is black and white, but also for the gray cases. What we're going to share is what we have learned makes a big difference for our patients. The first 3 goals that we are going to cover today is really what we want you to know. So we want you to know what the major causes of vertigo are. And we really want you to know how to define vertigo and what in the world dizzy means. If I were to ask you all right now, what does dizzy mean? You each would probably have your own description. So we're going to talk about that. And then we're going to pull in why the big 3 are key. The reason we want you to know that is because that's how you're going to get the most help. Now, what we want you to do is to make a plan. And that's what we're going to cover in our 4th point today. We're going to help you make a plan on how to get help. Or maybe you're here listening for a friend or a family member. And the reason we want you to make a plan is because we know it will make a difference in your life or the life of your loved ones if you're dizzy. So, hey, let's get started. We've got some great information to share. And Sarah is going to start us out with covering the amazing parts of the vestibular system and why we sometimes become dizzy. One second here. Sorry about that, Sarah. Some things got moved around a little bit, guys. There we go. All right, Sarah, you ready to rock and roll?
Yep.
All right.
All right, so thanks for the introduction, Andy. Like Andy said, I'm Sarah. I'm a student physical therapist from Ohio University. I appreciate you guys having me on here today to help you guys figure out the causes of your dizziness. So what are the major causes of vertigo? Some of this stems from the vestibular system. So when we talk about the vestibular system, we talk about it in kind of 2 parts. So we talk about the peripheral vestibular system, which is just a fancy way of saying your inner ear. So that's this structure here in the center of the picture that kind of looks like a snail. And then we talk about your central vestibular system, which is mostly your brainstem and your cerebellum. So our job as physical therapists is to determine, utilizing the big three, if your dizziness is coming from your inner ear, your peripheral vestibular system, or if it's coming from your central vestibular system, or is it a combination of the two? And how do those affect your nervous system and your fight or flight response? So in order to utilize the big three, we have to know about the anatomy and the function of the vestibular system. So here you can see a picture of the vestibular system, and you can see that it's a teeny, teeny, tiny structure, and it lives in our skull beside our ears here. So despite the vestibular system being such a tiny, tiny structure, it has a lot of responsibilities for our body. So the circular part, we'll go back to that slide. The circular part here is responsible for our hearing, and the projections off of that are responsible for our balance. They're responsible for maintaining equilibrium. They detect motion. So when we move up and down and side to side, or when we turn, those tubes there help us determine how we're moving. But not only that, they also determine our eye movement. So together with the central vestibular system, the inner ear controls how our eyes move. So we can utilize the big three to help determine the causes of dizziness based on the functions of the vestibular system. So one of the main causes of dizziness that we see here at Tusk is BPPV. So this is when the rocks in the inner ear break loose. Okay, so we all have rocks in our ear, and those are called otoconia. And the rocks in the inner ear are adhered to a very thick honey-like substance in the inner ear, in the center here. So I've got a model here of the inner ear. This is kind of showing you what it looks like. And when those rocks break loose, you can see that they get into the tubes. And when they get into the tubes, that can make us feel intense spinning sensations. It can make us feel nauseous. It can make us throw up and just have a general sense of overall uneasy feelings and off balance. So how do we know if your dizziness is coming from your rocks, or if it's coming from your inner ear, another inner ear problem, or your central vestibular system? Okay, so that's why we utilize the big three to really narrow down where your dizziness is coming from. So next, Andy is going to talk even further about why we get dizzy and some of the major causes of dizziness.
So thank you, Sarah. You did a great job explaining the function of the inner ear and brainstem and cerebellum. You know, guys, it still amazes me that the inner ears move our eyes when we move our head. That's just crazy. But like Sarah said, and you're going to learn soon what that means to you when we cover the big three, that's how we figure out why patients are dizzy. So let's look at the big picture. There is a really cool specialized dizzy doctor. His name is Timothy Hain. He's a neurootologist in Chicago. And he believes that about 50% of the reason that people become dizzy in general in the whole population is due to inner ear, brainstem, and cerebellum problems, okay? And the other 50% has to do with like other medical issues, or sometimes we don't know exactly why patients are dizzy. Now, it's interesting because Dr. Hain is an outpatient physician, but when we look at what doctors Edlow and Newman-Toker have figured out, they did a study. They are emergency department physicians who studied over 9,000 patients over a 13-year period of time, and they figured out that about 50% of their patients who were dizzy had to do with inner ear, brainstem, or cerebellum problems. And the other 50% had to do with just general medical problems like hypoglycemia, anemia, heart issues, toxicity from medications, things like that. Now, before we get further along, everyone needs to know that there are sometimes dangerous reasons for dizziness. And doctors Newman-Toker and Edlow figured out that about 15% of those patients that they saw over a 13-year period of time had dangerous forms of dizziness. And those are the kind of dizziness that if you don't do something about it, there's going to be a very poor outcome. So those are emergencies. And those have to do with like low blood sugar, anemia, heart attacks, heart dysrhythmias, sodium, potassium, calcium issues, and strokes. So it's good to keep that in mind. Now, when it comes to physical therapy, which is what I am and Sarah's going to be soon, we did a study over a 6-month period where we tracked patients who came to see us with a general diagnosis of vertigo. And this was out of 231 patients. And we found by using the big three that about 54% of those patients we saw had calcium crystals loose. And the other 22% had an inner ear weakness. We call that a hypofunction. And we're going to cover what that means here in a little bit. But it just kind of gives you an idea of what some of the major reasons of dizziness are that we see. And that might be a little bit different than what the emergency department will see and what outpatient specialized doctors might see. But what I think is really fascinating as we get to this big three being key is that Dr. Edlow and Newman Toker broke down the major causes of dizziness into 4 major syndromes. Now, think about an emergency department physician. They need efficiency. They need to know exactly what's wrong with their patients quickly so that they help save their lives, or they move them along so that they can help save the next person's life who comes in. So I just want you to know these 4 major syndromes, and then we're going to get to more important information soon. Acute vestibular syndrome, okay? That's the first thing you need to know. That will cause an intense spinning sensation that will last hours. And the most common cause of that is a virus. That virus is known as vestibular neuritis or labyrinthitis. The second most common cause is a stroke. Then there's triggered episodic vestibular syndrome, okay? That is usually triggered, or it's triggered when you move your head, it brings it on. The most common causes of that are benign paroxysmal positional vertigo and orthostatic hypotension. Then there is spontaneous episodic vestibular syndrome. And the most common causes of that are vestibular migraine, Meniere's, or transient ischemic attacks. Finally, there's chronic vestibular syndrome. And the most common cause of that is what we call the vicious cycle of dizziness, or 3PD, and anxiety. Now, we're going to cover these in more detail over the next few minutes, but what I really want you to know as we prepare to unveil what the big three are is that our goal is to prevent acute vestibular syndrome from becoming chronic vestibular syndrome. We don't want a problem that starts to last for months. We want to prevent triggered episodic vestibular syndrome from becoming chronic, and we want to prevent spontaneous episodic vestibular syndrome from becoming chronic. Let me simplify this, guys. Here's how it works. Those 3 syndromes are like a tornado that comes through a town. They come on, they wreak havoc. Things are going crazy. Things are spinning like crazy, okay? But then they go away. But they often leave a trail. And the trail that they leave leads to chronic vestibular syndrome, okay? Now, there are more reasons for what causes all of those different syndromes, and that's more than we want to cover today. We just want to introduce some of these major concepts. Here's what is fascinating. All those 3 syndromes, acute vestibular syndrome, spontaneous episodic vestibular syndrome, triggered episodic vestibular syndrome, are the trigger that leads to this vicious cycle. And I want to just go through it real quickly. What happens is when you spin like a top and you're feeling miserable, your brain actually does something called sensory reweighing. It says, I can't trust my ear because I'm spinning like a top. I'm going to become more visually dependent. I'm going to rely more on my eyes. And when I do that, the problem is that sometimes I'm going to get dizzy watching things move. If I'm sitting still and I see things move around me, I'm going to start to feel yucky. My neck's going to tense up and my head's going to feel foggy, full, and pressure and heavy. Then I'm going to become real aware of my world. I'm going to become hyper vigilant, and I'm going to sense normal movement as abnormal. So I'm going to think when I'm standing still, I'm going to feel those subtle movements. My speedometers and my GPS systems in my feet and ankles are going to be heightened. It's going to make me think I'm moving faster than I actually am, which is going to make me feel off balance. And so I'm going to tense up. I'm going to try to control my balance. I'm not going to let the unconscious system work anymore. I'm going to try to take conscious control over that. My balance muscles are going to freeze, and that's going to cause me to tighten up and be more off balance. And of course, I don't want to be off balance, so I'm going to avoid doing things because I don't want to move my head. I don't want to get dizzy. I don't want to experience all this. It's miserable. But as you all know, if you don't use it, you lose it, right? And if we become weaker, we start to fall, or we become afraid of falling. And did you know you can get what's called height vertigo on your own 2 feet? Now, if you've ever been up on the CN Tower on the glass floor or in New York City and walked across that floor like I have, I get these immediate sensations of crazy dizzy feelings in my head when I'm up that high. Well, our patients can have some of those same sensations on their own 2 feet. And so we start to use our hands for balance because we don't trust our system. And that leads to more anxiety. And guess what, guys? This vicious cycle just keeps going, all because of one of those major triggers. So what we really want to do is understand all the pieces of your dizzy pie. It usually starts with one of those 3 syndromes, and then there are usually several reasons for why patients are dizzy, okay? I have patients that will check out those 3 syndromes and will say, it doesn't look like you're there anymore. You don't have those anymore. And they'll say, well, why am I still dizzy? Well, it's often because we're in the vicious cycle. So how do we figure this out? What do we do about it? It starts with the question, the most important question, what does dizzy mean? All right. That is a very confusing question. If I were to ask you what dizzy means, you probably wouldn't be able to tell me. But we know that 75% of patients can be diagnosed by history alone. What does lightheaded mean? If I were to ask you, what does it mean that you say you feel lightheaded? You might say, well, I feel like I'm off balance. But that's not what we learned in therapy school. We learned that lightheaded should mean a feeling like you could pass out. And what exactly is vertigo? You know, many of us learned that that's a spinning sensation, but I have plenty of patients who come in and say vertigo means that I'm off balance or that I feel motion sick. So there's a lot of confusion about what dizzy means. So much, guys, that I have collected over 435 different descriptions that patients have told me. So the word dizzy is not a one size fits all. The way you describe your dizziness is going to be different than the way your neighbors describe it or the way your loved ones describe it. So what do you mean by dizzy? Used to be the best question, but not anymore. We have the big 3, and that's what we're going to share with you. Sarah is now going to unveil the first of the big 3.
All right, so now that we understand why we get dizzy and some of the major causes of dizziness, we can talk about the first of the big 3, which is triggers. So what do we mean by triggers? Triggers are an activity or something that we do that causes our dizziness to come on. So it could be bending forward or tilting our head back, or maybe rolling in bed. It could be laying down in bed or sitting up from lying down. Sometimes it could be really quick movements that bring on our dizziness. But the key here is that there is an activity that is bringing on your dizziness, okay? So the challenge with this is knowing whether your dizziness is triggered or if it's exacerbated. So what do we mean by that? If it's triggered, that means at baseline, you have no dizziness. So if you sit completely still, or if you lie down completely still, you have no dizziness. And then suddenly you roll in bed and you're spinning like a top. Okay, that's triggered. Now, exacerbated is when you have dizziness at baseline. So, no matter what you do, nothing eases your dizziness. You have dizziness all the time at rest. Okay. Movements might exacerbate your dizziness, they might make it worse, but it's not what brings on your dizziness. So, the challenge for you is to reflect on your dizziness and say, do I have dizziness at rest? And if so, do movements make it worse? If I don't have dizziness at rest, what movements or what activities bring on my dizziness? And that'll be important for helping us determine where you fit in the categories for determining the causes of your dizziness. So, Andy's going to touch on that a little bit next.
So, as you are reflecting on what Sarah so well described, the difference between triggers and exacerbated, I want to take these four major syndromes that help us figure out why you're dizzy and explain how they work. Acute vestibular syndrome. You're going to have a sudden onset of spinning. There is no trigger, and it is terrible. It is intense. Okay. When you move, it will be exacerbated, but you didn't cause it by moving. On the other hand, you've got triggered episodic vestibular syndrome. This is triggered. This does come on by usually rolling over in bed, bending over, tilting your head back. And once it's triggered, it will cause motion sickness and yucky and, vomiting. But it was originally triggered by head movements. And if you hold still, it goes away. Spontaneous episodic vestibular syndrome, you can still be sitting still and it just comes on its own. You did nothing to bring it on. Once it starts, when you move, it is exacerbated. Okay. Chronic vestibular syndrome can be both triggered and exacerbated. So you've just learned one of the first of the big three. You might be saying, is that really that valuable? And I'm telling you guys, it is. This is how we figure out what the initial cause of your spells are. Now let's dig a little deeper. Let's unveil number two, which is even more helpful as we dig in. Sarah's going to unveil that to us now.
So, the second component of the big three is timing. So, what do we mean by timing? Timing refers to the amount of time that you spend in your dizzy spell. Okay. Does your dizziness or does your spinning last seconds? Does it last minutes, hours? Does it last all day? Does it last weeks or months? So, this is what we're referring to when we say timing. Okay. Now, the challenge with timing is understanding the difference between your intense spinning sensation versus motion sickness. Okay. Oftentimes, our patients will come in and they'll say, I've been spinning for 3 days straight. And really, they may have only experienced spinning for a few seconds. And what they felt for the past few days is motion sickness or icky, yucky feelings, or like they're foggy or fuzzy. Maybe they felt nauseous for a few days after their intense, dizzy spell. So, what we want you to do when you're thinking about your own dizziness and trying to peel back the layers of the onion on the causes of your dizziness is understand, is this the intense spinning part? Or is this just the aftermath of the intense dizzy part? And how long is the intense spinning really lasting? And we're going to use that information along with your triggers to help put you into one of the categories or maybe multiple categories for your dizziness causes. And Andy's going to talk about that in the next slide.
So, Sarah, I love how you said maybe one category and maybe multiple categories, because we've learned sometimes our patients have a few of these syndromes all at the same time. But let's stay focused on timing. So first, the big three was triggers. As you're reflecting on what you feel when you're dizzy, is something you do bring it on? Or is it just always there and when you move it makes it worse? The next one of the big three is timing. If you hold still and do not move, how long does the intense part last? For instance, with acute vestibular syndrome, you will spin for days. Yes, for days. And some of you have. And you could imagine how terrible that is. While you're spinning, you're probably vomiting. You're probably terribly nauseated. You do not want to move. You probably went to the emergency department. They probably hydrated you, probably did a CT or maybe an MRI to try to figure out what's wrong. Triggered episodic vestibular syndrome will last seconds. Now, many of you will say, oh, I never have spinning that lasts seconds, but I'm going to challenge you on that. If you have triggered episodic vestibular syndrome, when you lay down, when you roll over, if you hold perfectly still and do not move, hold still, do not move. How long does the intense part last? Not the yucky, not the uh-oh, here it comes, but then it doesn't. Not the feeling like you're on the verge, but how long does the intense part last? Usually you're going to find it lasts less than a minute. Spontaneous episodic vestibular syndrome, you're going to have spells that last minutes. So these are going to be like 20 minutes, 30 minutes, 40 minutes. You know, you're having a Meniere's attack, you're having a migraine. It's like the aura that comes with it, okay? A TIA, we're lasting minutes. And then chronic vestibular syndrome can last months to years. So now that we have covered the first big two, isn't it interesting that in order to get help, the first two of the big three have to do with what you all are feeling? Sometimes we've learned it's our role as therapists to help you learn how to communicate this dizzy language because it can be so confusing. But now Sarah is going to unveil number 3. And when you put all of these combined together, they have a lot of power. So Sarah, take it away.
All right, so here we are. The third component of the big 3 is nystagmus. Okay, so that might be a term that you've never heard before, but we're going to explain what nystagmus is. So nystagmus is involuntary eye movements. So that means that it's something that we cannot control. So it's our eyes that moves in 2 phases. So we have a fast phase and a slow phase, which basically means that it moves quickly in one direction and then slow in another direction. And that's how we name it, okay? So as you remember back earlier when we were talking about the vestibular system and the central vestibular system, we talked about how the inner ear and the brain stem and cerebellum help move our eyes. So they move them in certain patterns that we can identify and help us determine the cause. Is it coming from your inner ear? And if so, which part? Or is it coming more so from your central vestibular system? So we're not asking you all to be nystagmus experts or to learn today how to identify your own nystagmus. But what we will ask you to do is that when you're going through these intense spinning attacks, is to video record your eyes. So if you have a cell phone or some sort of video camera, and you can record your eyes during those intense spinning attacks, and then you can take that information to a healthcare provider, your physical therapist, your doctor. That will help us put the pieces together along with your triggers and timing to help you figure out the cause of your dizziness. Okay, so next, Andy's going to describe how sometimes nystagmus is not always abnormal, and he's going to explain the difference of when that's abnormal and normal.
So Sarah, great job of explaining the importance of videoing the eyes when you're dizzy. You see, when we put together triggers, timing, and a video of your nystagmus, we can do a better job of figuring out which category is causing your symptoms. Now, let's have a little fun with this. This is my daughter rolling down a hill.
Hey, guys, you ever wonder why motion sickness kicks in for some of us when we are about 18 years old or older? You know, when we were younger, we did some crazy things. One of them is rolling down a hill. All right, honey, stop. Stay on your back. Now look up. And crazy things. Look at that. Okay? Wow. So anyway, as life goes on, we don't do things like that. What you feeling, baby doll?
Dizzy.
What kind of dizzy?
Like really dizzy.
Is it spinning?
I
Yeah?
feel like I'm flying.
All right, well, good job.
Okay, so that kind of gave you an idea of how nystagmus occurs and how you can actually video nystagmus. You can see it. Now, you can cause nystagmus for fun. You can do that to your kids or your grandkids. spin them in a chair, roll them down a hill, and then stop it and look in their eyes. But let's see what happens when nystagmus is not so fun.
There you go. Good. Open your eyes. Open your eyes. Eyes open. Eyes open. There you go. Eyes open. It's okay. Hang in there. You're doing good. You're doing good. Deep breath. It's going to get better. You're doing good. Oh, great. See? Got better. So we'll tell you, you got a bad case.
Okay, so you could hear the terror. You could hear the fear, the sense of not being in control. But notice how there was a timing to that nystagmus. It lasted seconds. But if you're in her shoes, she might say that lasted minutes or even hours. It's terrible. And it provokes motion sickness that could last hours. But the intense spin went away in 30 seconds or less. So interesting how nystagmus works and how it's part of the big three. So being able to video your eyes during those attacks is so helpful. Take a look at this one. So that last video we showed you was an example of triggered episodic vestibular syndrome, or BPPV. This individual is in acute vestibular syndrome. Imagine what it would be like to lay there, not move, and have your eyes constantly be jerking, fast followed by slow. And what we are trained to do is to name the nystagmus and tell based on its characteristics, like what Sarah said earlier. Is it coming from your ear? If so, what kind of ear problem? Is it coming from your brainstem, cerebellum? Where are these eye movements coming from? And would you believe that sometimes doing the bedside tests are actually more helpful than a CT scan during the first 24 hours of onset of symptoms at figuring out why you're dizzy? So if you can get that video, it's so powerful to lead us in the right direction. So let's reflect the big three: triggers, timing, nystagmus. As we look at these four categories, you'll see that nystagmus is present in all of the three and a little bit sometimes in chronic. So I hope you understand the power of figuring out if you have nystagmus, what your triggers and what your timing are. Now let's talk about treatment. We only have a few more slides left, and then we'll leave some room for questions. We want to talk to you about what to do. Here's what you do. You make a treatment plan, okay? You say, all right, I know I'm having these spells. I need to get an accurate diagnosis so we know how to treat it. It's not a one size fits all. You don't just wave a magic wand and fix everything. So first, what we need you to do is we need you to communicate your triggers or the absence thereof to your healthcare provider. We need you to communicate your timing, and we need you to video your eyes during an attack. That's what's going to get you help and help us figure out what to do next. Sarah is going to talk about what to do after that.
Step 2 is going to be talking to your doctor or a physical therapist and maybe an audiologist who specializes in dizziness about the best treatment plan for you. So based on that diagnosis that we come up with, based on your triggers, your timing, and your nystagmus, we can put together a treatment plan that suits you and your needs best. So we're going to briefly talk about some potential treatment options for each of the four dizziness categories that we've been discussing throughout the presentation today.
So I know you want to know what to do. Well, it really depends on the cause of your dizziness, okay? So we got to figure out why you're dizzy before we can tell you what to do about it. What do you think the diagnosis of vertigo is? That really doesn't tell me anything. It's not a diagnosis, it's a symptom. So if you're in acute vestibular syndrome, you're spinning like a top, you really need to probably go to the emergency department or call your physician and find out what they want you to do, because the goal is survival. We want to make sure nothing bad is happening to you. And then if it is turned out that it's just your inner ear, you still need to survive, because you're going to be nauseated, you're going to be vomiting, and we don't want you to get dehydrated, because we know that also makes you dizzy and can be dangerous. But we'd love for you to video your eyes during that attack. If you could take that video to healthcare providers who understand what this stuff means, then we can tell you what happened when it started. You got to get on the right meds and off the meds at the right time. We don't want people on meclizine forever, but there sure is a time and a place for it. Okay. And then we have special vestibular adaptation exercises that we do for that once the person can function again, once they can move. Then I'd like to talk about spontaneous episodic vestibular syndrome, okay? This is where I get a lot of fulfillment because so many patients who have these sudden attacks and nobody knows what's wrong with them. When I have my patients video their eyes, we figure out their triggers and timing. It helps us figure out what's wrong with them. Sometimes it's seizures, sometimes it's TIAs, sometimes it's migraines, sometimes it's Meniere's, sometimes it's other types of things. But that's how we start to create a treatment plan for this. Sarah's going to talk a little bit about how we treat triggered episodic vestibular syndrome and chronic vestibular syndrome.
We'll start with chronic vestibular syndrome, and this is going to be similar to spontaneous episodic and acute vestibular syndrome, in that we still want you to take that video recording of your eyes. So as we've already mentioned with chronic vestibular syndrome, that can be preceded by any of these three syndromes. So it could be acute vestibular syndrome that turns into chronic, or it can be trigger episodic or spontaneous episodic vestibular syndromes that then turn into a chronic vestibular syndrome. So in order to properly treat chronic vestibular syndrome, we need to know the underlying cause. And we find that out by using your timing, your triggers, and your nystagmus. So once we know what those big three are, we can better bring down your nervous system and get you ready for rehab. So what we mean by becoming elite is exactly that. So a lot of times in this chronic vestibular syndrome, our nervous system is heightened and we are very hypersensitive to any movement. As Andy has already described, we get into that vicious cycle of dizziness, okay? So in order to become rehab ready, we need to become our best self. We can do that by improving our diet, improving our sleep. We can do that through meditation or spiritual meditation or whatever it is that your belief system, okay? Then once we start to bring that down and get you rehab ready, we can do vestibular rehab, which consists of habituation. And what that means is moving our body in ways that originally caused us to be dizzy, because now we want our nervous system to say, this is okay. We can do this. Bring it on, baby, is what Andy likes to tell our patients. Okay, so we do a little bit of habituation. We might introduce new ways of doing things, which we would call substitution. And we can also try the adaptation that we would have tried in acute vestibular syndrome as well. So the key with chronic is knowing the initial cause first to help narrow down your treatment plan. So next, triggered episodic vestibular syndrome, we still want you to video record your eyes, okay? And if we find that the cause of your triggered episodic vestibular syndrome is blood pressure related, so that orthostatic hypotension, we might recommend and encourage hydration. And we might recommend you consulting with your doctor to make changes to your medication. Now, if we do see that the crystals are loose and that you have BPPV, we can move your head in special ways to help put the crystals back in place. Okay, so this can take one treatment or it can take several treatments depending on how many of those crystals are loose. Okay, so Andy's going to show some before and after videos of real patients that we've treated in the clinic who have or had BPPV.
So I'll start by, thank you, Sarah. Great job with that. I will start with showing that first original video that we showed you.
Open your eyes. Open your eyes. Eyes open.
You can see the nystagmus.
It's okay.
Every time she moves her head, this is what happens. That's why she spins. And the crazy thing is we can tell her when her spinning starts and when it goes away by viewing her nystagmus. All right. That's why nystagmus is one of the big three. Now watch what happens 20 minutes later after doing a repositioning maneuver. Same patient. Here we go. Tell me if you hear a difference or see a difference.
You know what? That's what I say. I didn't get dizzy.
So you could hear her. She was shocked. She was waiting. It's going to happen. How do you take a terrible problem away in 5-10 minutes? And how do you prepare your brain for being healed like that? I joke and say that's the treatment that makes us famous. But guys, it really does work that well. And what you really need to know is you need to know if your rocks are loose or if they're in place if you deal with triggered episodic vestibular syndrome. 1 second, I'm gonna get out. Here's another one. We'll show you the before and the after. I like this video because there's some eye abnormalities. You can see the nystagmus a little easier. So you can see a crescendo, it's building. She's spinning. She's spinning, she's spinning. Okay, and we can tell that she's dizzy because we can see it in her eyes. That's why we need you to video your eyes. Then what we do is, if you watch the screen there, we move the head in special ways, which John Epley initiated several years ago, around the 1980s, and he studied this. We move the head in special ways, and we put those babies back, put those rocks back, and then we retest, okay? And if you watch this retest, about 20 minutes later, tell me if you see a difference. Okay, so the eyes aren't spinning anymore. They're not dizzy anymore. So I like to say there's red light dizziness and there's green light dizziness. And you need to know which dizziness you have. If you're spinning, we need to get video of it. We need to know which syndrome you're in so we can know what to do to help you, okay? And then if that leads to the vicious cycle of dizziness, we need to know which part of the vicious cycle you're in so we know how to treat it. Thank you all for listening. Sarah is going to conclude our presentation today.
So now you guys know the big three. So now you know how to identify and communicate your triggers. You know how to identify your timing and how to determine if you are having intense spinning attacks or if what you're feeling is the aftermath, and if you're feeling motion sick versus intense spinning. And then the importance of video recording your eyes so that a healthcare professional like your physical therapist can determine the direction of your nystagmus. So these three things together are going to help us help you figure out the causes of your dizziness and help you get treated for your dizziness. Okay, so what I want you to do is take this information to your healthcare provider, follow the treatment plan that we've set out for you, and we hope that you found this helpful today, and we appreciate you all hanging out with us for about 45 minutes. Thank you all.